This is Dr. Charles Parker, and you're listening to Core Brain Journal. It's a place where I connect both fresh discoveries and interesting different perspectives from advanced mind science with the realities of real people and everyday life down on Main Street. Welcome aboard, folks. This is Dr. Charles Parker at Core Brain Journal one more time, and we have an individual who's really seen the world of psychiatry on a global level, and he is a person who has hospitals in countries really all over the world, and he's going to talk to us about the details of the evolution of psychiatry in a variety of countries. And so welcome Dr. Tonmoy Sharma. Thank you for coming on.
Thank you, Dr. Parker, for having me on your show.
So I'm going to read a brief intro, folks, and then we'll find out a little more about his background and who he is as a person. Dr. Tonmoy Sharma is the CEO of Sovereign Health, and he has been recognized with numerous awards, honors, and grants for his work in advancing mental health and its treatment in the United States, in Europe, and in Southeast Asia. His background as a psychiatrist has provided him with unique insights into his management of facilities in the United States, Europe, and India. He's been a prolific researcher and scientist. He's authored or co-authored more than 200 peer-reviewed articles and 5 books on schizophrenia and mental illness. Under his leadership, Sovereign Health has grown from a small facility in San Clemente, California, to a national brand spanning 5 states and comprising 9 fully functioning facilities that treat addiction, mental illness, co-occurring disorders, brain wellness, and behavioral health programs for eating disorders as well. And by the way, folks, we have 2 other interviews with his colleagues which will be listed in the show notes. One individual for eating disorders and another person on addiction medicine. Both of them are leaders in his Sovereign Health community. So we'll talk more about that in a moment. Under his leadership, Sovereign Health has been on the Inc. 5000 fastest growing companies for the 3rd year running. Dr. Sharma has been a member of several editorial boards as well. He's a peer reviewer for 14 international medical journals and has served on various advisory boards governing the development of antipsychotics. So, as a member of the Royal College of Psychiatrists in London, and he is involved in the Changing Minds campaign. I like that because we're thinking the same kind of byline a little bit. He helped lead a 5-year initiative to combat the stigma of mental illness. He was recently elected as a board member of the National Alliance on Mental Health in Orange County. And get this, folks, he currently co-hosts KABC in Los Angeles, 790 AM, and the title of the program is In Your Right Mind, a cutting-edge weekly radio show that covers various topics on the latest headlines in behavioral health. So we're really looking forward to hearing your remarks, Tonmoy, on a number of issues. Could you take a moment here just to introduce a little more who you are and how you arrived at this place in your life?
I guess serendipity played a big part in arriving at this place. There wasn't a 5, 10, 15-year plan. I was interested in the brain, so I did neurology, did a bit of neurosurgery, but psychiatry was more interesting somehow. And research was what I was very interested in, and did research in the early stage of my career and in Ivy League institutions. At the Institute of Psychiatry in India, I spent a little bit of some time at Johns Hopkins in Baltimore, looking at brain imaging and functional MRI had come out for the first time. How you look at blood flow in the brain, because brain function has been of great interest to me. I think irrespective of what the structure of the brain is like, the functioning is the important part because that leads to outcome. Mm-hmm. After that, I felt that whilst it was important that we do research and all the Ivy League stuff, we needed to turn rational research into clinical reality. And that's where I started developing some software to measure cognition and founded the cognition group, and did several, and the software was used in several studies for FDA clinical trials, and then also Sovereign Health, where we said, well, can we look at how we can treat mental illnesses like schizophrenia and also addiction disorders and substance use disorders, and how can we move away from the usual treatment into measurement-based care and recovery management. And you mentioned the differences in the fact that I've experienced in several countries. I qualified as a physician in India, so I've got experience of what healthcare is like in India, in Europe, at least in the UK, and then very closely related to the rest of Europe. So I used to frequently collaborate and lecture in Europe. And then obviously running since 2009 or so, running the systems in the US and seeing the changes in the US, especially in the behavioral health field. So professionally, that's what I am, and that's what I'm doing.
So say that last part again. I didn't quite hear you, Tonmoy, when you said especially in the what? What was that?
Especially in the behavioral health field.
Oh, behavioral health, yes.
Yeah, in the behavioral health field, because since the Affordable Care Act, the behavioral health field has undergone some tremendous changes, and more people have been able to access treatment. Though it's doubt, there is some, there's people have. I feel that maybe there is some worry as to whether this will continue in the future or not. But as of now, that's the case.
I'm looking forward to talking more about that. Now, you were raised in India. When did you come over here, or did you go through the UK before you came over here? How did all that work out?
Yes, I trained in I trained as a resident at the University of London, University College London. Then I was at the Institute of Psychiatry, King's College London, and the Institute of Psychiatry at the Maudsley Hospital. I was very fortunate to train with really big names in psychiatry. Gerald Russell in eating disorders is coining the term bulimia at that time, and I had there were people who had written big textbooks that I had the privilege of having everyday lunch with. And so you walk down the corridors and you think, whoa, this is wonderful. You had obviously the Kriplanian kind of psychiatry at the Institute of Psychiatry and the Maudsley Hospital had its influence in the way I viewed psychiatry. And then this was no longer a discipline that, well, was by the sidelines, and biological psychiatry was really growing up and getting its place on the main table. So it was a very exciting time, and brain imaging, especially with functional MRI, we were, given that radioactivity was not involved, we could do studies in children and women, and we could literally peer inside the brain and on repeated scans look at how blood flow and how the function of the brain changed over time, whether it was as a result of drugs or as a result of CBT. I mean, indeed, recently there's a paper published that by some of my previous colleagues that have shown that CBT, cognitive behavior therapy, causes significant blood changes in blood flow, and these remain a year after CBT has been started.
Now, very interesting. I've done SPECT imaging myself since 2003, and so we share that interest in functional brain, because once you see that, it does change you as a professional. You feel like you want to dig deeper, and the answers are not there. They're somewhat there, but you always think there's another group of helpful answers around the corner.
Well, I guess that is the tantalizing bit in terms of brain imaging, in terms of what we should what we did, and that's really what drove me. I was interested in the interaction of cognition and pharmacology. I led the section of cognitive psychopharmacology. Fortunate to get a number of grants at that point, and we published extensively both in the American Journal and the Archives of General Psychiatry at that time, and the proceedings of the National Academy of Science. Several papers, including the first paper on fMRI of patients undergoing risperidone treatment, showing changes in the frontal cortex, dorsolateral prefrontal cortex, how that changed once you had people going on to this so-called newer atypical antipsychotics at that point. This was like late 90s. So, and that's why my interest in seeing what goes wrong in the brain with mental illness, and I include addiction in that, and then what can we do to reverse this? And that's been the foray. Somehow in academia, you point to the problem and that's about it.
Yes.
It's good to go into the treatment bit and say, what can you now do about it? It's like, okay, you have a diagnosis of MS, now what? So, and I think it's important that we now bring that from the bench to the bedside. And that's what we are doing. We're still a training center for postdocs, pre-docs across all our sites at Sovereign, from Pompano Beach right up to California. But it doesn't mean that we cannot continue to do what we were doing, maybe not at that level. But we can also provide good treatment for people that is not just evidence-based, but that is measurement-based. And we need to move on from being evidence-based to being measurement-based. So because we don't have this, my sort of bee in my bonnet is that there are no measurements that people use routinely. There is no blood pressure equivalent, this 80 by 120 equivalent. And we need to change that mindset. We need to create that change in the country.
Well, I completely agree. I mean, we're everything you're saying, I'm in such complete agreement with, and I didn't realize that we would be having this kind of conversation. I looked at your bio, of course, and I could see there were some parallels, but the whole idea of cognition and how uniformly it's ignored in modern psychiatry. To me, it's amazing. It's almost like you have to have either traumatic brain injury or Alzheimer's to qualify for cognitive evaluation and prefrontal cortical understanding, and yet it's pervasive. I mean, what's the? I'm asking you rhetorically, but what is the percentage of brain function that's cognitive? I mean, we're so fascinated with affect that how a person actually functions in changing reality, and that's one of the reasons functional neuroimaging is so important, because reality changes and the mind is adjusting to reality, and labels are outdated, static, and reductionistic. So, but the standard of care is labels, and it's an interesting thing because I think it does something to significantly interfere with the evolution of human beings who are seeking care.
Yeah, I'm in agreement. I think those were the principles on which we set up Sovereign, saying that we need to be different than the rest. Especially in addiction treatment, there was little to no. It was even less. First of all, there was little to no acceptance of medication-assisted treatment in 2009 when we first started this in San Clemente. Things have changed a little bit now in that sort of broader community. And addiction has remained kind of in the fringes of medicine, if you like. If you think of psychiatry as sometimes being in the fringes of mainstream. So I think that it's important that we realize that given the epidemic with the opioids, and given that a person is dying every 17 minutes in this country, we have a moral obligation to make sure we provide the best standard of care.
Quite agree. Absolutely true. Now, how does a busy guy like you, you've got 9 facilities here, you actually manage the facilities in India and UK as well? Or are you consultant there? How does all that work?
Well, we have got leaders in each of the facilities, and I'm very fortunate to work with a group of people that I have personally appointed, and we appoint people for the why. I've always believed that, and the how and the what we can teach them most of the time.
Mm-hmm.
So if you have people who have like-minded, then you can work with them. If times are tough, we can scale back. And so we are an organization. We have no external capital. There's no venture capital. There's no private equity involved. We've just forged our own way because we wanted to do this. We wanted to do things slightly differently than the rest of the people, and wanted to show that you can still do reasonably high-flying science and have a behavioral health network and a system of care. So we have a chief medical officer, a chief clinical officer, Dr. Millie, I think you've spoken to already.
Millie, yes,
going
sir.
to speak to him.
Mm-hmm.
And Dr. Veena Kumari, who is extremely well published, and I was quoting her work when I talked about the fMRI study on cognitive behavior therapy, which has just been published. It has, it took the world by storm. So to have somebody like that as the chief scientific officer, we are privileged to indeed do that. So I think it's important for us to recognize that you can still have that level of both clinical and scientific competence, and be also the training sites, formal training sites. Each of our sites is an APIC training site, which is for pre and postdoctoral psychologists. So we're competing with Johns Hopkins, with Harvard, UCLA, etc. Well, at the same level, and they are we're advertising. And we're part of that same group where people are choosing where to come for their postdoctoral training and the pre-doctoral training. So we want to also have our clinical competence as well as our academic excellence at the same level. We don't get the traditional grants, etc. We invest quite a lot of our money back into questions that we want answered that will improve care of patients. So that's the kind of, it gives us the freedom of doing what we want to do without all the baggage, if you like.
So true. Now listen, I'm going to ask you a hard question because listening to you is really inspirational. It's something few people have been able to do. I've known a few people that thought about these things. I myself grew frustrated with hospital psychiatry years ago because the whole business of how you cookie cut individuals and how you can be held accountable for whether they meet outdated diagnostic standards and how all of that seems to be so removed from the reality of people's lives and how they get well. How do you actually, let's take a moment to talk a little bit about that, because some of our listeners, I'll have Dr. Maley and Janet's, what was Janet's last name? It's not...
Janet Whitney.
Yes, Janet was the eating disorder person, and we'll have we'll have there in the show notes. But how do you see it as a CEO of this widespread organization? How do you actually identify and correct some of these issues that we're talking about that are resistant issues in terms of keeping a person in the hospital, measuring and addressing their specific underlying biomedical issues, and then translating it into a program? What's your thought about that?
Well, I think our peers are mainly the insurance companies, and there's very little of private pay. We kind of serve Middle America. Some of our facilities are starting to go in network, but we're mainly out of network, accepting PPO plans. We do serve, say, the longshoremen in the West Coast, but that's where we are as an organization. So having said that, there is a large population that we are able to serve still. We have taken the view that given the fact that we are not driven completely by the bottom line, we can establish standards that will allow us to show the rest of the industry that you can do certain things that don't have to be that expensive, but you can still do the measurements that will allow you to show how good or bad your assessment, the person's mental state as well as brain state. So we do that. We do a 3-day assessment, and then the treatment. That treatment needs to, whether it's neurofeedback, biosound, whether it's cognitive remediation, cognitive enhancement therapy, all these different things, part of brain wellness that we do. We build this in, and we've argued with our payers that this is important. It's a large part of it, both within the community and within all the insurance payers, is about educating them and telling them, hey, we've been doing the wrong thing for a very long time. And that is why, as a payer, you've been paying a lot. And secondly, for the community, that's why you have a revolving door patient.
That's so true.
On and on and on.
So true.
And you don't have the continuity of care that you need to have. You see what we are doing, looking at addiction. For example, we are treating a chronic, relapsing and remitting illness with episodic care. Mm-hmm. We are treating this like an infection. So, you go into detox, you go into residential treatment. What is this? And then after that, you're discharged with a one sheet which says patient came in and then is discharged on these drugs with no information whatsoever. That's a typical discharge note. And then they're going to some outpatient or some IOP who has no clue about what has happened to the patient. There is no continuity of care. Forget about a warm handoff to the next provider. And this allows me to then compare with Europe and what we did and how we had the continuum of care, that when a general practitioner refers somebody to me, I would have the patient's history, at least a summary of that history, what meds the patient has been on. And in the latter stages of my career, I could even log into the system to see what they had, what was going on with the patient. Mm-hmm. And we don't even know they were taking drugs that were prescribed by the gynecologist, that the OBGYN and what they were prescribing and whether that would have any interaction with what I was giving. This is, it's scary sometimes.
No, it's amazing. It's, I think it's scary all the time. I mean, and talk about recidivism, yeah. It's the basis of recidivism because exactly what you're saying is the standard of care. And if you're doing, providing care on such a superficial level, recidivism and coming back into the hospital is almost inevitable.
Yes, and the providers, and sometimes people that I have spoken to rather passionately in various group meetings of different societies, I don't know if they're really interested because income is dependent on the person coming back in, and somehow it's built into the business plan. So why should they be interested really in preventing the relapse? The SAMHSA and the NIDA, the National Institute of Drug Abuse data show that 60% of the people discharged will relapse within 6 months. So, okay, that's income for me. If I can get them to come back to me, rather than saying, let us adopt what mainstream medicine has adopted. If I were a surgeon, it's not about how many times the person comes for other surgeries or similar surgeries. It's about what is my infection rate, how long or how quickly can I discharge a patient from hospital. That is the metric that I would be judged on if I were a surgeon. So how are we not judging people on that metric? And people say, what is the relapse rate you have? Well, I have no control what the patient does once they discharge. They can go to a loving family or friends that look after them and encourage them to be, clean and sober and be on the straight and narrow, or they could go to a frat house and relapse within a week. How is my treatment relevant to that? And with using the surgery analogy, you could have a surgery for weight problems and have your stomach stapled, and you go and then you eat like crazy, live out of your fridge or refrigerator, and then you put on weight, and you said the surgery was unsuccessful. No, the surgery was successful. Your stomach is small in size, but you just start eating. So treatment really starts, I wrote in the LA Times recently about the treatment really starts once one discharges from this inpatient, the residential detox facilities. That's when treatment starts. Very much like if you had a cardiac event, like a heart attack, go into ICU. When does treatment start? Okay, they have saved your life and whatever else. And so you've got to change your lifestyle. You've got to look at how, losing weight perhaps, and then even attending a group of, an evening group, maybe once a week, twice a week, whatever it is, for people who may have had a similar event. That's no different from what should happen in substance abuse treatment. However, again, I go back to the analogy of treating this like an infection. Just saying, okay, you come in, we sort this out, and you're done. Well, okay, how can we not treat this like diabetes, like cardiac disease, like COPD? We have models that exist that are successful, and yet we are completely oblivious to it. I was talking to one of our peers the other day, I think it was Aetna, Cigna, and I was saying, let's do a case rate, pay us for case management, which they have traditionally been unwilling to do. I said, we will keep these patients well, and we'll even have some skin in the game, that we will treat them. If they are relapsed, that we will treat them. We won't charge you for it. But at least the outcome will be better, because I am worried about what outcome our patients have in terms of how we can reintegrate them back into society. That's success, not whether somebody has had some relapse. And this whole, our entire, language is based on shame and failure.
So true. So true.
Do we talk about a diabetic relapsing? Do we talk about a diabetic relapsing? Do we talk about, they graduate, they marble out, alumni. We're alumni of our colleges, of our universities, all of that. So every time if you have to go back to college each time, or university each time, have you not failed? So for a diabetic, somebody suffering with diabetes, the blood sugar is either out of range or within the range. So why can we not do this? Why should we have a 28-day admission each time? Why can we not, if they have a lapse, for example, and why can we not bring them in for a tune-up for 7 days? Let's bring them in. It's kind of unheard of in this. So we're creating all these changes. It's not been easy, because these are, at least they think that, or some people seem to think these are rather radical ideas. And I just want to make sure that we are just treating people in the way a chronic illness should be treated. That's all.
Yeah, I mean, it's really just accepting reality the way it actually is. And biologic reality does live in all these human beings. And, as we were talking about earlier, brain scans will take you to the beginnings of that biologic reality. I think of the brain as the canary in the coal mine if you're looking at chronic illness, because actually brain dysregulations are related to the entire being, just as you said a moment ago. If you can get the mind straight with cognitive behavioral therapy, you can actually see the brain changes. So there are many things that affect brain function. I think what's going on, and this is obviously an armchair guess, but my experience in speaking with really thousands of physicians over the years, lecturing nationally on just using psychopharmacologic agents accurately and correctly. What I found is that people did not really want to think more deeply about things. It was like, just give me a protocol that I can follow. I don't want to have to think about the individual. I don't want to have to really look at the nuances of how they're metabolizing that medication. I don't want to ask them questions which would be invasive regarding their hormonal state or anything else that would have to do with their biology. I just want to go ahead and give them a cookie cutter solution and cross my fingers. And if that doesn't work out, it's their fault, it's not mine. And that is the pervasive standard.
Yeah. And that's always the issue in terms of how things go. I think that there is the positive thing, if you like, is that there are people like yourselves and others that think differently and think differently from the herd, if you like.
Mm-hmm.
And so it is important that they have the wherewithal and the guts really to raise their voices and say, well, I think it's time to change. It's time to finish this and time to hit this. It's time for a change. We need to relook at this, and it's no longer acceptable to just put everybody into the same protocol.
Now, Tonmoy, we're thinking so similarly, and that's one of the reasons we are really so pleased to interview individuals like yourself here on Core Brain Journal. It's great fun for me because it's a great learning process. I mean, you're teaching individuals, but in the process of teaching individuals, we both learn from the practice, and we're closer to getting it right. Now, please help me with this concept, because I've heard differing opinions about what's going on in the rest of the globe. My own experience doing consultations out of the country, even now, is that it's spotty globally in terms of where people are with the evolution of mind science. I've been very surprised at how retrogressive the UK is regarding the way they think about medical care, but I could be wrong in that, and I wanted to get your opinion about, you're in some very key areas, India and the UK. Are they ahead of us in certain respects in terms of this comprehensive care model that you're talking about?
Oh, yeah, especially Europe and especially UK. I think they are way ahead in terms of what the comprehensive care models have been way back. The UK had and has had the care program approach, where in collaboration with the psychiatric patient, and often it's quite difficult if somebody is psychotic, that you work out a care program that you are going to be discharged, and you'll have the community nurse, psychiatric nurse coming to visit you. You'll have your, depot injections of antipsychotics. And remember that Europe has a much less of a problem with depot injections than the US has had.
Say a little more about that, because some of our listeners don't even know what a depot injection is. Take a moment for that.
Okay, yeah. This is traditionally still Johnson & Johnson, part of Johnson & Johnson, got a different type of injection. It traditionally has been an antipsychotic injection that is suspended in an oil base. So it is and what it does is it's injected either into the upper buttock area or to your arm, and then it releases the antipsychotic slowly over a period of time, and it is the preferred method of treatment for people who don't adhere to a medication regime, if you like. We used to call it non-compliance in the past, and I think we call it non-adherence now. So and when I used to practice, had time to do some, I remember patients that would be ideal candidates for this. And then afterwards, we've had antipsychotics in a more water-soluble base as well. And the difference is that it's less painful because if it's in a water-soluble base. So long-term care is important because there you're not passing on expenses to somebody else. It's the same payer. It's a single-payer system. And that's where the difference is. You're not passing on the cost. You can pass on it on to some other department, but ultimately it's the same payer. So this continuum of care from the general practitioner to, so we knew, and we had catchment areas. We knew where the patient was coming from and what would happen. And even if they went to an area far away, you were sending copies of the charts, and there was a lot of communication. And if you had a transfer, you knew a lot about the patient and what had happened. And that allowed us, I believe, at least to provide a better standard of care. And I think patients benefited. And having information available like that, where the patient might not be a good historian, and in an interview, you may not be able to elicit all the information that you might want. It allows us then to provide better care. Now, there are advantages and disadvantages. People obviously pay for it, through their taxes, and one might have a view about that. But just looking at it from in isolation, if you like, apart from the financial point of view, that it's a much more this doesn't happen in India. India is more like the US. It's more privately based, even though there are government hospitals. And there isn't the continuum of care. But in Europe, certainly in most of Western Europe, you would have that, you have that system of care. And so it was quite surprising when I first started working at Johns Hopkins, that was 1990 or so. And that I was saying, where is this patient going to go? Oh, we don't know. Salvation Army, perhaps. I said, okay, who's the family practitioner? Doesn't have one. In the UK, it was like mandatory almost for everybody to have a GP or a general practitioner. Mm-hmm. So there are differences in terms of the system of care, and these are different, and one has chosen the reason for it, but it becomes very difficult to deliver care if you don't have enough background information, and sometimes it could be frankly dangerous, especially if the person is seeing people from even different specialty. Forget about the same specialty, and sometimes people could be doctor hopping or doctor shopping. And so I think that it's drug interaction, and to find out and sharing of that information because of confidentiality issues, not only in mental health, and then it increases to a significant extent in the substance use field. As you very well know, that it becomes impossible to do this. And people will say, okay, I don't want you to talk to my family. How am I going to know how much you're drinking? Because you're not going to tell me the truth, are you? So these are constraints that we have. But within those constraints, we can deliver the kind of care, given the environment of sort of managed care at this point. We need to do the best we can for our patients.
Well, these are very interesting observations, and I'm wondering as you're speaking, because I really hadn't thought about that aspect of the UK and having a structure on discharge. What we do a little bit in the country, and in this country, as you know, is there are a variety of step-down systems like intensive outpatient and partial hospitalization. And they're helpful, but it's interesting because even as a step-down, very often the same protocols are followed. There's no evolution in terms of dealing with the underlying chronic issues more completely. It's like, okay, we're just going to make sure you take your medications, and that support is helpful. It's better than no support, but the chronic illnesses, in my view and from my own personal experience, take so much more work and so much more understanding, and it's part of the reason that individuals resist going further down the road. Not only does it seem unconventional, even though it's completely peer-reviewed and biologically accurate, it just seems unconventional still, and that's why we have this big split going on between quote-unquote functional medicine and traditional medicine. One of my pet peeves is I think we should just change the whole thing to comprehensive medicine. But it's interesting that doesn't happen. If you go to a functional medicine meeting, and you know this because you live in California, go to a functional medicine meeting and you'll hear them actually saying negative things about psychiatry in very obvious on the stage ways. And then if you go to a traditional meeting, now I will say that I was at the American Psychiatric in Toronto last year,
Mm-hmm.
and I was very pleased to see the direction the American Psychiatric Association is going. I mean, I went for one of the reasons is I feel like I'm on the edge myself, and I wanted to know how far on the edge I might be compared to where my peers were. And I was very reassured. I don't know if you've been to an APA meeting recently, but they did a very good job of talking a number of difficult, comprehensive, nuanced issues, including the immune system dysregulation as it affects brain, which is one of my favorite areas, and I think it's another overlooked area. So I think it's changing, but I think these kinds of conversations are absolutely essential on top of specific structured activities. Now, again, I'm not trying to put you on the spot. I'm just trying to be educated by your perspective. But do you folks in Sovereign have a specific program when they leave, or how do you actually follow up in some constructive way? What have you brought to the table on that one?
Well, we have a continuing care team. Anybody that comes to Sovereign is followed up for 5 years without, and we can't really bill unless they participate in our e-therapy program, and a lot of people don't necessarily do so. And they can be in some IOP or PHPs, say in Texas, for example. So, but our idea is to follow them up. We do several surveys, but we are the virtual case managers for them. And we do this out of our India office. We have a software program, plus we have live case managers that they can reach out to 24/7. Because of this, we're able to keep in touch with people, find out how they're doing, what keeps them well. It enables us to learn. Mm-hmm. And so, if you're talking this talk, we need to walk this walk and say, well, how can we have a system in place? And that's why I can go to people like Aetna or the people at Aetna and say, look, we have a system in place. We have done the pilots. And this is what helps people stay out of a hospital or a residential treatment facility. Mm-hmm. And if we put the system in place, and if you pay for it, you're not going to pay the $20,000 or $30,000 that you're going to be paying for the next detox and residential level of care.
Yeah, that would be a hard sell, I would think. Do you actually have some managed care companies that support that activity, or how does that actually work from a business point of view?
They have been very interesting. They have been very interested. I must say that they're saying that, well, this doesn't fit into their model because we are not, it will be very difficult for us, given our level of, master's level and PhD and PsyDs that treat patients at Sovereign, to be able to just accept a low-level HMO rate, which is in network. So we were looking at a case rate and what we can do, proposing a model that's different from their usual model, saying, mm-hmm. Let us take responsibility for 4 months, 6 months for this patient, and then they could go to a local IOP, but we still case manage them. Mm-hmm. We still get this. So, it's a different model, but it allows for that continuum of care, at least during the most vulnerable period of relapse. Mm-hmm. We know that, almost 50 to 60% of people relapse during that time, and we want to decrease that relapse rate and make that successful. And if we empower them with enhancing their cognitive function, their set shifting, their prefrontal cortex, their function, their executive function, and anything else that we can, that allows them then to navigate through life in a much better way than they otherwise would. So we are trying many things that are a hybrid of what we've done in academia, what evidence is out there, and how we can measure. Because I believe that what you can't measure, you can't improve in any way. Yeah. And so it's been this kind of loosey-goosey stuff that
Yeah.
or this is my gut feel. Well, how do you know? Is my blood pressure, is it 180 and you feel that this is okay, that's fine? So, what are our standards? We have achieved parity, but are we at par with surgery, with OBGYN in terms of what we do? Is it that patient has improved? Improved what? He's telling you he has improved.
Yeah.
Have you done a PHQ-9 even? It doesn't take you that long. It's free. Just to see, is he depressed, is he not depressed? Anything that gives you a measure. Let the nurse do it. Let anybody, or your intern, whoever it is. Some independent measure that says that there is some progress or lack thereof over time. At least it tells you might need to change meds or do something or relook at the case again.
Follow-up is so necessary, and I just love what you're saying because it's absolutely so relevant. I mean, we are in a very important changing time in terms of chronic illness, and so many of these psychiatric problems are really biologic problems and chronic illnesses. And if we don't measure them, we will remain in denial and we'll continue to think, as the people around Galileo's time, that the sun was rotating around Rome. And, it looks like it does, so that must be what it is. And
and they persecuted him for it.
Yeah, so. Right. Yeah, it's a Galileo mind moment. I have an article on the Core Brain Journal site about that. But well, listen, Tonmoy Sharma, Dr. Sharma, this is a very interesting conversation. I think we need to bring it to a close a little bit. I'm going to have all your connection material in the show notes, but I think the one issue is that you're not in one place. I think this is a very important point, that you and your organization are in multiple places, and thank goodness we're being heard by a number of individuals in different parts of the globe. And I think that's then a reassuring point for our listeners that an individual like you is thinking about the application on a much broader scale with Sovereign Health and thinking about really making a difference in people's lives in a much more integrated way, a more comprehensive way than has currently been in practice, for the most part. So do you want to leave the Sovereign Health URL real quickly as we wind up?
Yeah, it's www.solvehealth.com.
Good. There you go. Good. Do you have any closing remarks then, Tonmoy? Anything you want to say as we wind up here?
It's been a pleasure talking to you. I'm so pleased that people in 83 countries listen to your journal and have access to such high-grade information. I am awed by what you've achieved in this short span of time, and it's a privilege to be asked to talk to you on this journal. So thank you for asking me. I hope that with Sovereign Health we can make differences in the lives of people that come to us for help. So the rest of it, I think if we can change the way people perceive treatment, that we would have achieved our aim.
Well, thank you, Dr. Sharma. The feeling is quite mutual. It's been a real privilege talking to you. And for right now, I'm going to say goodnight, folks, and thank you, Dr. Sharma. Thanks for listening to Core Brain Journal. We're working every day behind the scenes to bring you reports that connect research benches with those street trenches. Here we share the complexity of mind science because, as you know, details really do matter. One of the most pervasive misunderstood challenges is how commonplace medications, like those written for ADHD, are used so regularly without clear guidelines. If you think you'd like more specifics, take a minute to download my 2-page PDF packed with video links and references on the absolute essentials of how to start ADHD medications. They're easily available at corebrainjournal.com/start. Thanks for listening. Do connect and stay tuned. Together we can make a difference.